Good evening, everybody. In today's lecture, we'll learn about schizophrenia. Now, what do we mean by schizophrenia? The word schizo means split, and phrenia means mind. So, schizophrenia means splitting of mind. Schizophrenia is a syndrome. Schizophrenia is a syndrome in which there is a scattering or the fluctuating pattern of thinking. Fluctuating pattern of thinking. The symptoms of schizophrenia varies according to the people. There are three types of symptoms which are produced. First, we have the positive symptoms. Then we have the negative symptoms. And the third, we have the cognitive symptoms. Now, before going into this, normally the human symptoms that are normally in any illness are the exaggeration of the normal physiological processes. Say, for example, everyone has a heartbeat. Everyone has a heartbeat. When the patient, if the patient is having tachycardia, which is simply the increase in the heart rate. This is the exacerbation of the normal physiological processes. Then we have a normal body temperature. In the fever, the body temperature increases. In the body temperature. So the word positive indicates that there is something new feature which is added in the normal physiological processes or which does not have any physiological counterpart. It does not have any physiological counterpart. So in the positive symptoms, we have say delusions. We have delusions and we have the hallucinations. We have disorganized speech, disorganized behavior, and or catatonic behavior. Now, in delusions, what happened? In delusions, the patients have false belief. The patients have false beliefs. Actually, there are two types of delusions. The delusions of control and the delusion of reference. In delusions of control, what happens that the patient feels that there is some external force, person, or thing which is controlling their actions. So this is known as delusion of control. And in delusion of reference, say for example, if the patient is watching a television and the newscaster, the patient may think that the newscaster is directly speaking to them. Then we have the hallucinations. Hallucinations means any type of sensation which may not be present. Say this sensation may be visual. These may be visual hallucination, that is the patient may see the things which might not be actually present. The patient may hear the commands, or the patient may hear the voices. So these are known as auditory. So these are the main type of hallucinations, that is visual hallucinations and auditory hallucinations. The patient might feel that even feel that someone is touching him. So these all come under hallucinations. Then we have disorganized speech. In a disorganized speech, the patient may have the random jumbling of the words. The patient is not able to form one exact sentence. Okay, so this comes under disorganized speech. And then we have the disorganized behavior. Disorganized behavior means that the patient may have bizarre behavior and the facial grimacing. Facial Grimacing. Now, what do I mean by grimacing? That the patient may make unusual facial expressions. Okay, so this comes under disorganized behavior. And then we have the catatonic behavior. Now, catatonic behavior is related to the movement, posture, and the response imbalance. Means the patient may have the resistance to the movement, and the patient may become unresponsive, which is also known as stupor. Okay, so these all, that is delusion, hallucinations, disorganized speech, disorganized behavior, and the catatonic behavior comes under positive symptoms of schizophrenia. Then we move towards the negative symptoms. Now, what do I mean by the negative symptom? So the word negative means that something is removed or reduced from the normal physiological process. Something is removed from the normal physiological process. Say the patient may have the reduced emotions. The patients may have the lack of interest. The patient may have the flat effect. Now, what do I mean by flat effect? Now, say for example, a patient is schizophrenic, and if he's sitting on some bench and suddenly a monkey comes, so what the normal people do, they start running here and there. But a schizophrenic patient may be sitting idly as if nothing is happening. So they will have a flat effect, that is inappropriate response. Inappropriate response, which is also known as anhedonia. Anhedonia. Okay. Then the patient may have the allogia. Allogia is nothing but the poverty of speech. That is the lack of content in the speech. Like, for example, if you ask the schizophrenic patient that, do you have kids? Then the patient may reply, yes, instead of telling that, yes, one boy and a girl. So the patient may have the lack of content in the speech. Then we have the evaluation, that is the lack of motivation, a motivation. The patient may become demotivated. Then we have the cognitive symptoms. This is all about negative symptoms. Then we come to the cognitive symptoms. Now, in the cognitive symptoms, the patient is not able to remember things like the memory of the patient, the understanding, and the memory of the patient, the understanding is impaired. The patient may become confused. So the patient may unable to memorize the phone number, or the patient may not be able to remember the address. The patient will have forgetfulness. Okay. Now, there are three phases of schizophrenia. The patient cycles through three phases of schizophrenia. So the first phase is known as a prodromal phase. In a prodromal phase, the patient becomes withdrawn. The patient may feel depressed, and the patient may become anxious. The patient may experience anxiety. The patient starts spending time alone. Okay, so the patient basically becomes withdrawn. Then this prodromal phase is followed by the active phase. Now this active phase has serious symptoms. These symptoms includes all the positive symptoms, that are the delusions, the hallucinations, the disorganized speech, the disorganized behavior, disorganized, catatonic behavior all comes under active phase. Then followed by the active phase is the residual phase. In the residual phase, mainly we have the cognitive symptoms. Okay. In the cognitive symptoms, the patient may experience again the impaired memory, forgetfulness. The patient may become depressed, and it's just like the prodromal phase. Okay. Now we come to the diagnosis of the schizophrenia. The diagnosis of the schizophrenia is based on a tool which is known as DSM. This DSM stands for Diagnostic and Statistical Manual of the Mental Disorder. There are which are mainly used for the diagnosis of various mental disorder. So there are many DSM manuals which have been published. That is DSM 1, DSM 2, DSM 3, DSM 4, and DSM 5. So in schizophrenia, we'll use the DSM, that is Diagnostic and Statistical Manual 5, and based on this, any two of the following symptoms should be present in the patient. Any two of the following symptoms should be present in the patient. Now, which are those symptoms? First, we have the delusions. Then we have the hallucinations. Again, disorganized speech, disorganized behavior, or the catatonic behavior. We also have cognitive symptoms, but it is of less importance in a diagnosis. Now, out of these, any two symptoms should be present in the patient, and out of these two, one should be at least delusion, hallucinations, or disorganized speech. Out of these two, any one should be delusion, hallucinations, and disorganized speech. Now, all these symptoms should be present in a patient for at least 6 months. All these symptoms should be present in the patient for at least 6 months, with at least 1 month of active phase. Okay. I repeat, according to the DSM 5, any two of the following symptoms should be present in the patient. That is, any two of these symptoms should be present. Either delusion, hallucinations, disorganized speech, disorganized behavior, catatonic behavior, or cognitive behavior. Cognitive behavior is of little less important. And out of these behavior, any one symptom should be the delusion, hallucination, and the disorganized speech. And these symptoms should be present for at least 6 months, out of which the 1 month should be active phase. What was in the active phase? The delusion has all of these. So if the patient experiences this, the patient is diagnosed to be schizophrenic. Okay. Now, what are the causes of schizophrenia? What are the causes of schizophrenia? So mainly the exact mechanism of the schizophrenia is not known, but when the schizophrenic patients are given antipsychotics. Now what antipsychotics does, antipsychotics medications blocks the dopamine D2 receptor. Okay, it blocks the dopamine D2 receptor, that is, it reduces the dopamine levels. Dopamine is a neurotransmitter which is present. It reduces the dopamine levels in the blood, and what happens that all the symptoms were seen to be reduced. So the scientists conclude that there was something related to the levels of the dopamine. The pathophysiology lies within the increased levels of dopamine. But these antipsychotic drugs were not very much effective. So this added to the conclusions that there might be other neurotransmitters like GABA or serotonin or norepinephrine that might be present in the pathophysiology of the schizophrenia. So accordingly, the treatment there are treatment options available, which we'll discuss further. Then the other cause was the twin study showed that the twin study which was conducted showed that the schizophrenia can happen due to the genetic basis. Say, like if the mother or the father is schizophrenic, then their offsprings may have the 2 or 3 fold increased risk of getting diagnosed with the schizophrenia. Then the third cause may be environmental. Uh, Say the early prenatal infections, prenatal infections, or we can say the autoimmune disorder can also cause schizophrenia. Okay. Now it was found that the men, in the mid 20s, are more prevalent for the schizophrenia, whereas the females are more prevalent to the schizophrenia in the later age, in the late 20s. And the females have lesser serious symptoms as compared to men due to the estrogen mediated regulations of the dopamine. Due to the estrogen mediated regulation of dopamine levels, the female patients are often have the lesser uh, serious symptoms as compared to men. Now we come to its treatment. So as discussed that we have antipsychotic drugs, right? We have antipsychotic drugs. So in these antipsychotic drugs, we have two types. We have a typical antipsychotic drug, and we have atypical antipsychotic. This typical antipsychotic is also known as first generation antipsychotic, or these antipsychotics were used during 1960s for curing the schizophrenia and other psychological problems. And then the atypical antipsychotics were discovered. Many more antipsychotic medications were discovered, so these are known as atypical antipsychotics. They are also known as modern antipsychotics, or they are also known as second generation antipsychotics. Now, which classes of drugs comes under typical antipsychotics, atypical antipsychotics? What is the basic difference between typical and atypical antipsychotics? We'll discuss in detail. So first of all, suppose this is a typical antipsychotic drugs. We'll draw a typical antipsychotic drug. This typical antipsychotic drugs has 5 domains. Okay, this typical antipsychotic drug has 5 domains, out of which it has one main domain. Okay, say this is a typical antipsychotic. Okay, now this typical antipsychotic has 5 domains, out of which this domain is responsible for blocking the D2 dopaminergic receptor. These are the D2 blockers. Okay. Now, as they block the dopamine D2 receptors, that is, it blocks the binding of dopamine with the dopamine receptors. So, what happens? It has good effect and it has bad effect. Okay, the good effect is that it produces antipsychotic effect. Secondly, it produces anti-emetic effect. How it produces anti-emetic effect? Like in the brain we have a chemoreceptor trigger zone. So this chemoreceptor trigger zone have neurons which release dopamine. They have the dopamine receptor. So when these D2 receptors, when these typical antipsychotics are given, they have the D2 receptor domain which blocks the D2 receptor and the binding of the dopamine. What happens? It produces anti-emetic effect. The chemoreceptor trigger zone is normally responsible when it's activated, it produces MSS. So when it blocks the dopamine receptor there, it produces anti-emetic effect. So the good effect is that it produces antipsychotic effect, it produces anti-emetic effect. The bad effect is that this typical antipsychotics classically produces extrapyramidal symptoms, side effects. Extrapyramidal side effects, and it also increases the level of prolactin. Prolactin is basically a hormone which is present in the females, which is responsible for inducing lactation from the mammary glands. So what happens? It increases the levels of prolactin and it can cause the hyperprolactinemia. Hyperprolactinemia. Now, what is extrapyramidal side effects? What are these extrapyramidal side effects? We'll see in detail. These extrapyramidal side effects are, the first extrapyramidal side effect is dystonia. Okay, now approx 80% of patients taking typical antipsychotics develop extrapyramidal side effect. This is the most common side effect. Yeah, and it can be due to the acute use and it can also be due to the chronic use. Okay. So in that, the first we have the dystonia. Dystonia may develop within few hours to few days. Okay, dystonia develops within few hours to few days. What is dystonia? Dystonia is the positive postural muscle contraction. All the muscles that are present behind on the back, they are contracted. So what happens? The patient develops dystonia. The patient may have inappropriate posture. This is known as dystonia. Then second, if the patient does not develop dystonia within few hours or few days, then the patient comes up with another extrapyramidal side effect, say akinesia. Now akinesia develops within few days to few weeks. Few days to few weeks. Now this akinesia is also known as Parkinson-like syndrome. Also develop Parkinson-like syndrome. Why? Because it brings up the symptoms similar to Parkinsonism. The patient experiences tremors. The patient experiences rigidity. What happens in Parkinsonism? What happens if the patient is having Parkinson? Then the patient develop. If the patient is having Parkinson, then the patient develops akinesia. The patient develops tremors. The patient develops rigidity. Okay. What is akinesia? Akinesia is basically difficulty in initiating the purposeful movements, the voluntary movements. Difficulty in initiating purposeful or voluntary movements. Like if the patients want to walk or get up from the chair, the patient has the willpower, but the system does not support. The system does not follow. So this condition is known as akinesia. Then we have rigidity, in which our limbs of the hands and becomes a hypertonic. Hypertonic means they become contracted. They become contracted and they become rigid. They become very rigid. And then we have tremors. Okay, the patient starts developing tremors. Now, this akinesia is also known as hypokinesia. Can also be said as hypokinesia. So, in the patient which comes up with a akinesia, that is a Parkinson-like syndrome, may develop a akinesia, tremors, rigidity. So, while treating these patients, during the Parkinsonism, the hypokinesia is treated with levodopa, and this tremors is treated with anticholinergic drug. Why? Why such? Because in the basal ganglia in a brain, there is a balance between dopamine and there is a balance between cholinergic system. Okay. What is happening in the typical antipsychotics that they are blocking the dopaminergic receptor, blocking the dopaminergic activity. So what happens? The cholinergic activity increases. The cholinergic activity increases. Okay. And the patient develops extrapyramidal symptoms. Tremors occurs due to unopposed cholinergic activity. Unopposed cholinergic activity. Okay. This is about akinesia. Then we have third extrapyramidal symptom, which is akathisia. What is akathisia? Akathisia is motor restlessness. Restlessness means the patient with akathisia is restless. They can't sit in the one place. They keep on running here and there, and even if they are made to sit forcefully, they'll keep their arms and legs constantly moving. So this akathisia develops within a few weeks to months. Okay. So all these extrapyramidal symptoms, that is dystonia, akinesia, akathisia, occurs due to the decreased D2 receptor activity, or due to the blockade of the D2 receptor, or due to the decreased dopamine levels. Due to the decreased dopamine levels, we can see this extrapyramidal symptoms. Now, there is one more very uh, common side effect of the typical antipsychotic, which is tardive dyskinesia. Tardive dyskinesia. What happens now? This tardive dyskinesia, one of the very important feature of the tardive dyskinesia is that this occurs due to increased dopamine levels. Now, how is this possible? We are giving typical antipsychotics, which are the D2 receptor blockers. It decreases the dopamine levels and it causes the extrapyramidal symptoms, which are the dystonia, akinesia, and the akathisia. But this tardive dyskinesia occurs due to the increased dopamine level. So this complication occurs due to the chronic use of antipsychotics. How this happens, the postsynaptic membrane, whenever we keep on blocking any receptor for a longer period of time, the postsynaptic membrane produces some extra receptors which are upregulated, that means they become extremely sensitive to even small amount of dopamine. So what happens that if the drug does not bind here, then even a small amount of dopamine binds in these receptors, what happens? The patient develops tardive dyskinesia. What are the features of tardive dyskinesia? The patient may have the lateral jaw movements. The patient may have the lateral jaw movements. Okay, the patient may have smacked lips. The patient may have the uh, like involuntary movement of the tongue, or as if they are catching fly with the tongue. They'll have such movements with the tongue. So all these features are known as choreo ethitidal oral facial disorder. Choreo ethitidal oral facial muscle disorder. The patient may have the lateral jaw movement, the patient may have the smacked lips, the patient may have the movements of the tongue as if they are catching a fly. So this condition is known as a tardive dyskinesia, which occurs due to the increased dopamine level. Then there is a very, very fatal complication. The good news is that it is rare, but this complication mainly occurs in the patients who are extremely sensitive to the dopamine receptor blocking, who are extremely sensitive to the dopamine receptor blockade. So what happens in certain patients that their muscles are strongly contracted. The muscles are strongly contracted. The muscles are strongly contracted. The patients may become rigid. This condition is known as catatonia. This is very important. This condition is known as this strong rigidity is known as catatonia. Okay. The patient freezes. The patient freezes in one position and they remain for that position for hours. Okay, so what happens, the patient, due to this severe contraction, the excessive heat is produced in the body, and the patient may produce the fever. Okay, the patient may produce fever, and due to this severe contraction, the muscle breakdown starts. So what happens, the myoglobin comes in the urine. Then also we have the enzyme that is CPK, that is cyclophosphokinase enzyme, which increases in the blood and it comes in the urine. Okay. Then the BP of the patient starts fluctuating. The BP is not stable. The BP may increase or the BP may decrease. The patient is not able to control the fever. Why? Because the normal body temperature is maintained by hypothalamus. Hypothalamus has dopamine receptors. Hypothalamus has dopamine receptors. So what happens? When this dopamine receptor gets blocked, they are not able to maintain the body temperature, and ultimately the patient is not able to sweat, and it produces a high grade fever. Okay. So this condition particularly is known as neuroleptic disorder. Neuroleptic disorder or malignant hyperpyrexia. Malignant hyperpyrexia. Okay. This occurs in a patients who are extremely sensitive to the dopamine receptor blockage. So now all these side effects are due to the blockade of the D2 receptor. This is just the effect of the one blockade of the one domain of the typical antipsychotics. Okay. Then we have the second domain. Yeah. This second domain blocks the alpha 1 adrenergic receptor. Now, normally, the what are the normal functions of the alpha one adrenergic receptor? Now, there are many alpha one receptor functions, but the two main functions which are to be remembered, that it maintains the vasoconstriction. Okay, normally it maintains the vasoconstriction. Okay, and it maintains the male ejaculation. So what happens? This typical antipsychotics blocks the alpha one adrenergic receptors. So what happens? It is not able to produce vasoconstriction and it produces hypotension. It produces hypotension and it produces the failure of ejaculation in males. Okay. It produces hypotension. It produces failure of ejaculation in males through the blockage of the alpha one adrenergic receptor, which occurs through the typical antipsychotic use. Then we have a third domain. Okay, this domain blocks muscarinic receptor or say cholinergic receptor. This cholinergic receptor, these cholinergic receptors are present in the cerebral cortex of the brain. Okay. So what happens when this cholinergic receptor in the cerebral cortex of the brain gets blocked? The acetylcholine is not able to bind here. So what happens? The patient develops confusion, forgetfulness, drowsiness. Okay. This muscarinic or the cholinergic receptors are present in the GIT. So what happens? It produces constipation. These cholinergic receptors are present in the urinary bladder, so it causes the urine retention, also fecal retention. Okay. So these are the bad news for the elderly patients. Okay. In the elderly patients, it do produce in a normal schizophrenic, but if these drugs are prescribed to elderly patients, and it can be more problematic as it produces constipation, urine retention, fecal retention. Okay. Then we have the fourth domain, which blocks the H1 receptor, H1 histaminic receptor, H1 histaminic receptor blocker. So what it produces? It produces sedation. Due to the H1 receptor blocking agent, it produces sedation. And we have the fifth finger. Now I would break this fifth finger. Okay? I would break this fifth finger. Why? This fifth finger or this fifth domain blocks 5-HT2, which is 5-hydroxytryptamine receptor, which are also known as serotonergic receptor. Now, why I broke this domain? Why? Because it is having a very less effect, negligible. Mainly, the typical antipsychotics has the D2 blocking action. It is the dopaminergic antagonist. Mainly, it blocks the D2 receptor. Then it has the unwanted side effects, that is, it blocks the alpha 1 receptors, it blocks the muscarinic receptors, it blocks the H1 receptor blocker. But it has a very minute effect, or say negligible effect, on 5-HT2 or the serotonergic receptor. So the main action, so the typical antipsychotic has the highest affinity for the D2 receptor. So what happens, so when they have the more affinity for the D2 receptor, automatically the level of dopamine increases, and the risk of the extrapyramidal side effects with the typical antipsychotic drug increases as compared to atypical antipsychotic drugs. You know why? Now we'll see the structure of the atypical antipsychotics. This this is the atypical antipsychotic. We'll draw them little fat because one of the major disadvantage of the atypical antipsychotic is weight gain. It is one of the major side effect of atypical. Okay. Then this atypical antipsychotic also has five domains, but it has predominant main domain that is 5-HT2 blocker. Then it has a reduced action. Then it has a reduced action on the histamine. It has a reduced action on the muscarinic. It has a reduced action in the alpha 1, and it has some of the effect on the D2 receptor. Okay, this is 5-HT2 and this is a D2 receptor, but this is the main effect of the atypical antipsychotic. What was happening in the typical antipsychotic? That this D2 receptor was main. And what is happening in the atypical antipsychotic? That the 5-HT2 receptor is dominant. Okay? And this D2 receptor, they are having affinity for the D2 receptor, but not as much as compared to the typical antipsychotic. So what happens? This atypical antipsychotics along with the 5-HT2 also blocks D2 receptor but less effectively. So what happens? Automatically the extrapyramidal side effects will be reduced. Nickel side effects will be reduced. Why extrapyramidal side effects will be reduced? Because this domain, which is the D2 receptor blocker, which is the main domain in the typical antipsychotic drug, which decreases the level of the D2 receptor, it does produces antipsychotic effect. But this decrease also has a many other side effects like the extrapyramidal side effects, which is dystonia, akinesia, and the akathisia. So automatically, this all extrapyramidal side effects will be reduced as it is not having that much affinity to the D2 receptor. It is having more affinity to the 5-HT2 receptors. That is serotonin receptors. So this is the first difference between the typical and the atypical, that the typical antipsychotics has first that the typical antipsychotics has the more affinity. I'll write here typical, atypical. That is the first difference, that it has more affinity, more affinity for the D2, as it has a more affinity, it produces more extrapyramidal side effects. Okay, and yeah, this blocks 5-HT2 receptor dominantly, also blocks D2 receptor but with a less affinity, very less affinity, very less affinity for the D2 receptor. So automatically it decreases the extra pyramidal side effects. This is the first increase affinity for D2, decrease affinity for D2, increases the extrapyramidal side effects, decreases the extrapyramidal side effects. Third most important difference is that if typical antipsychotics is used to eliminate the positive symptoms of schizophrenia. Typical antipsychotics mainly eliminate the positive symptoms of schizophrenia. What were the positive symptoms? The delusions, the hallucinations, the disorganized speech, behavior, everything comes under positive symptoms. So these typical antibiotics eliminate the positive symptoms. The atypical antipsychotics eliminates positive as well as negative symptoms. Positive as well as negative symptoms. Okay, this is the third difference. It eliminates positive symptoms. Typical and antipsychotics, atypical antipsychotics eliminates positive as well as negative symptoms. Okay, now which drugs comes under typical antipsychotics? The drugs, first drugs which come under, so actually there are three groups in the typical antipsychotics. We are discussing about typical antipsychotics. So there are three groups. First we have the phenothiazine, then we have the thiazanthines, and we have the butyrophenol. Butyrophenol. In a phenothiazines, we have the phenothiazines is again categorized into aliphatic. This is based on a structure. Piperidine, piperazine. Okay. Which drugs comes under aliphatic chain? Very important, very common. Chlorpromazine. Chlorpromazine comes under aliphatic phenothiazine group of the typical antipsychotic. Then we have the piperidine, which is the thioridazine. Okay, thioridazine. Then we have the piperazine. It has a piperazine ring in its structure. In that we have flufenazine. Flufenazine. Then we have the thiazanthine. So in that we have the thiotixin. Thiotixin. We have the butyrophenones. In the butyrophenones, we have very important drug, haloperidol. This chlorpromazine. Now, these typical antipsychotics are comparatively cheaper than the atypical antipsychotics. And so the chlorpromazine is a very cheap drug. It is commonly prescribed. The thioridazine is having a strong anticholinergic action. Anticholinergic action, as discussed that in the basal ganglia in the brain there is a balance between dopamine and the cholinergic receptors. This typical antipsychotics decreases the D2 receptor. So what happens? The cholinergic receptor activity was increasing, but the thioridazine, in addition to D2, also decreases the cholinergic activity. It is anticholinergic, so it decreases the cholinergic action. So what happened? The extrapyramidal side effects are reduced. But along with that, it has many other side effects. Say it as discussed that as it is an cholinergic receptor present in GIT, urinary bladder, so it produces the urine retention and fecal retention. Then the this cholinergic receptors in the eyes, it mainly produces the cycloplagia. It is a condition which occurs in the eyes. Cycloplagia. In the eyes we have ciliary muscles, right? These ciliary muscles adjust the size of the lens. Okay, so what happens? This ciliary muscle gets paralyzed. Okay, so as a result the patient develops the blurring of vision, which is again a side effect of the anticholinergic drug. And it also develop arrhythmia. Okay, it also develops arrhythmia. These are the side effects of the thyroidazine. One advantage, it decreases the extrapyramidal side effects, but it increases certain side effects, that is urine retention, fecal retention, blurring of vision, arrhythmia it produces. Then we have the next drug, which is flufenazine. It is also known as flufenazine diconate. It is available as the intramuscular injection. Okay, it is whenever it is given intramuscularly, it works for 3 to 4 weeks. So it is a choice of drugs for the patients who are extremely aggressive, who are not cooperative, okay, who cannot consume chlorpromazine, or who are not adherent to it. So we can inject it is a type of a depot injection, okay, depot intramuscular injection. It remains the inside for 3 4 weeks, and again after 3 4 weeks we can inject it to the patient. Okay, and then we have the haloperidol. Haloperidol is a very important drug. Haloperidol is a very very potent drug. It is having a main disadvantage is it is having increased frequency of extrapyramidal side effects. Haloperidol is having increased frequency of extrapyramidal side effects. What drugs are included in the atypical antipsychotics? Okay. Which drugs are included in atypical antipsychotics? So in that we have first clozapine. It is very important drug. Okay. It is, though it is a very potent drug, it is a very potent drug. It does produces toxic effect. Okay. It does produces toxic effect. Which toxic effect? Although it is very rare, but in a 1 to 2% of patient, clozapine produces a granulocytosis. It affects the bone marrow house of the patient. Bone marrow house of the patient. Okay, like for example, this is the bone marrow. In the bone marrow, we have stem cells, right? We have stem cells. The stem cells divide into the lymphoid cells and myoid cells. Okay, myoid cells. These myoid cells divide into granulocytes. Granulocytes. These granulocytes are divided into three types, that is neutrophils, basophils, and eosinophils. Okay, so what happens that in a 1 to 2% of patient, the clozapine, which is an atypical antipsychotic drug, inhibits the granulopoiesis. Granulopoiesis. Granulopoiesis is the process of the production of granulocytes. So what happens? The neutrophils, basophils, and eosinophils count decreases in a patient, and the patient may develop severe infections. Severe infections. Okay. So what happens whenever the clozapine is prescribed to the patient? The For the first 6 months, the patient is checked for its blood count every week. Okay, and if the granulocyte count is reduced, immediately the clozapine is withdrawn. And if everything is normal within 6 months, after 6 months, these tests are performed every 2 weeks or 3 weeks. Okay, then another atypical antipsychotic drug we have is olanzapine. Olanzapine is having multiple effects. Olanzapine is having multiple effects. Not only it is having antipsychotic effect, it is also having anti-anxiety, anti-depressant. Okay, it is also used as an anti-manic. It is also used in the obsessive compulsive disorder. It is very important drug. Okay. Olanzapine is not only used in antipsychotic, it also used in anti-anxiety, as an antidepressant, as an anti-manic, and in the obsessive compulsive disorder. Then we have another atypical, that is quetiapine, and we have the ziprasidone. Quetiapine and ziprasidone mainly produces arrhythmia, right? Along with the mechanism of action as discussed, each and every atypical antipsychotic blocks the 5-HT2 receptor. Okay, so as a side effect, it produces arrhythmia. Okay, it prolongs the QT wave. Like for example, this is the normal ECG. Okay, this is PQRS, and here is the T. So it prolongs the QT wave. Okay, what happens when this? It prolongs. There is no T wave. So what happens? What do you mean by prolonged QT wave? That means the period of the action potential is increased. The action potential is the duration of the action potential is increased, and the repolarization is delayed. The potassium efflux, that is the exit of the potassium from the intracellular to the extracellular, potassium efflux through the potassium channel is delayed. So what happened? The potassium cannot come out of this cell, so the repolarization is delayed. So as a result, the QT wave prolongation occurs, the action potential is prolonged, and it produces a very important side effects which is known as torsades points. It is a French term. It is known as torsades de points, but it is spelled as torsades de pointes. That is mainly the ECG reading comes like this. This is, and suddenly there is an inverted wave, and suddenly again there will be upward wave. So this is the torsades de pointes. Okay. Then we have the fifth drug, which is risperidone. We have other atypical drug, which is risperidone. We have the molindone. Molindone basically used in the hyperopsins gestures. Okay, hyperopsins gestures, and they are used in the vocal tics. Okay, hyperopsins gestures, vocal tics means there is, like for example, normally a 12-year-old boy have a deepening of the voice due to testosterone, but due to at the now in the hyperopsins gestures, the if the child is of 8 years old, then he may develop many other untoward gestures according to his age due to the testosterone, increased level of testosterone, and this occurs due to molindone and risperidone. Okay, and then we have another atypical antipsychotic, that is aripiprazole. Aripiprazole is the latest antipsychotic. Is the latest antipsychotic. Its mechanism of action is very interesting. It is a partial D2 agonist and a partial serotonin 5-HT2 agonist. That is, it it eliminates the partial action of the dopamine, and it eliminates the partial action of the endogenous serotonin. Okay, so comes under aripiprazole. So these are the examples of the typical and the atypical antipsychotics. Now, these antipsychotics are extremely lipid soluble. Okay, these antipsychotics are extremely lipid soluble. Why they are lipid soluble? Because they have to act on the central nervous system. Okay, they have to act on the central nervous system. They have to cross the blood-brain barrier, and the blood-brain barrier can be crossed by only those drugs which is having high lipid solubility, and these drugs are well absorbed through the oral route. Okay, they are metabolized by the hepatocytes. In hepatocytes we have the endoplasmic reticulum. Inside the endoplasmic reticulum cytosol we have the enzyme which digest the antipsychotics. Okay, the lipid soluble antipsychotics, and this is known as first pass metabolism. Okay, this is known as first pass metabolism. After going through the hepatocyte, it comes into the systemic circulation, and after coming into the systemic circulation, it crosses the blood brain barrier. Whatsoever blood crosses the crosses the blood brain barrier also crosses the placental barrier. Okay, also crosses the placental barrier. Now we'll go to the doses of these drugs. Okay. So as discussed, these are the first generation antipsychotics. And in that we have the chlorpromazine, flufenazine, haloperidol, thioridazine, thiorexinon. Also there are many other drugs. These are the commonly used drugs in schizophrenic. And the doses are the chlorpromazine we have approx dose is there 50 to 100 mg per day. Flufenazine is given 5 mg per day. Haloperidol is given 2 to 5 mg per day, and thioridazine is given 50 to 150 mg per day. Thiothixine is given 4 to 10 mg per day. Haloperidol also available in the pot injection. Okay, now as discussed, it produces catatonia, right? These drugs, first generation drugs, in some patient produces catatonia. In which patient it produces catatonia? Those patients which are extremely sensitive to the D2 receptor blockade. Okay, so in such a situation, what we do, there is a very special drug available for its treatment, that is dentrolene. Okay, dentrolene is given. So what this dentrolene do is that the sarcoplasmic reticulum which is present in the bones, the sarcoplasmic reticulum which is present in the bones, takes up all the calcium, and it relaxes the actin and the myosin. Okay, actin and the myosin in the bones, and what happens, the contraction is reduced. Okay, so automatically the symptoms are relieved. The second line therapy is we can also of course stop the antipsychotic drugs. Okay, and we can give the dopamine agonist. Why? Because this occurs due to the decreased dopamine level, right? So another we can give dopamine agonist as a treatment. And then we have the second generation antipsychotics, which is atypical. Okay, which are also called atypical. This are known as typical. Okay, the doses of the clozapine is 25 mg per day. Okay, and it is then we have the olanzapine, which is having multiple usage. It is given in the between the dosage range of 5 to 10 mg per day. And quetiapine and ziprasidone, which as we discussed has QT prolongation, produces arrhythmia. Quetiapine can be given 50 mg per day, ziprasidone 40 mg per day. Risperidone and molindone, that is used in hyperopsins gestures in the young patients, which produces certain features of the vocal tics. So it is given in the dosage range of 1 to 2 mg per day. Molindone is given 50 mg per day. Aripiprazole, which is the latest atypical antipsychotic, is a partial D2 agonist and partial 5-HT2 agonist, is given in a dosage range of 5 to 15 mg per day. Now, this extrapyramidal side effects, which is produced more in the as is typical antipsychotics. Okay, so there are certain medications which are used in the treatment of the extrapyramidal side effects. Okay, and with the atypical antipsychotics, what was the common side effects? Weight gain. Okay, weight gain. This is the common side effects in the atypical antipsychotic. So the drug used against the extrapyramidal side effects, as discussed, we have antimuscarinic. Why antimuscarinic? Antimuscarinic means anticholinergic. Okay, due to the increased action of the cholinergic receptor, as discussed, there is a balance between the dopamine and cholinergic. The atypical antipsychotic dominantly decreases the D2 receptor. So what happens? The cholinergic activity increases, produces extrapyramidal side effects. So in that case, the benztropine in the dosage range of 1 to 8 mg is given. As discussed, dopamine agonist here over here in case of catatonia, we can give dopamine agonist, which is biperidine, in a dosage range of 2 to 8 mg. We have certain benzodiazepines, that is lorazepam, diazepam, clonazepam can be given from 1 to 8 mg, diazepam 2 to 20 mg, clonazepam 2 to 8 mg. And we have certain beta blockers is very important. It is also used in dystonia, which is an extrapyramidal, widely used in dystonia, akathisia and echinacea, propranolol 20 to 80 mg. Okay, so apart from the schizophrenia, these antipsychotics have many other indications. It is used in schizophrenia, then it is used in schizo means schizophrenia, affective means Mood disorders. Okay, mood disorders means it is also used in a condition that have the pathology of schizophrenia and mood disorders, and is used in psychosis caused by the toxins and drugs. We can say that it can be used in a toxic psychosis. Okay, it is used in toxin psychosis. Tourette syndrome. Tourette syndrome, as discussed, that the hyper opsins, it is used in hyper opsins gestures, and it is used in a vocal tics, so it can be used in the Tourette syndrome. It is used in the intractable hiccups. Okay, it is if the patient is having hiccups and it is not stopping, the patient can take the chlorpromazine. Okay, then we have the it is also used in intractable pruritus, that is itching of skin. Promethazine is widely used in that. As discussed, it is also having anti-emetic effect due to the blockage of the D2 receptor in the chemoreceptor trigger zone in the brain. So the drug uses prochlorperazine. So this is all about schizophrenia and antipsychotic medications. Thank you.